So the echo had shown that EF is low, but our LV gram showed that EF is okay. So if you see medication, good medical therapy, but for the CAD wise, he is not on beta blocker because of COPD, cannot take statins, and he's on PCSK9 inhibitors. So cath was done late March, which had shown that he had left main disease, LED disease, and RCA was totally occluded. Since need for transplant and DAPT probably will be interrupted very early, the primary doctor cardiologist felt maybe get a heart team discussion, and then we can decide. And of course, because of the comorbidity, CTS, and the patient declined, so today he is here for PCI. So if we can go back to angiogram, so EDP was good. He had hydration for a few hours. EDP was 8. Creatinine is 1 today. So you see the EF is good. We didn't do our RCA picture, totally occluded. So this is where we are. You see that moderate left main disease, but more important is it is a trifurcation. So if we go with other criteria, where if you just see it on the V gram, you can see speckles, maybe moderate calcium, not severe calcium that we can classify on angiography, not ramp track. So you can see that calcium even here. So moderate left main disease and a significant ostial LAD, which you can see in cranial view. So in the caudal view, you have a large ramus, and there is this large circumflex, probably okay. So this is where we are. You can see that ostium of the LAD is involved. Of course, then we had done the IVUS, so we can quickly show the IVUS run. Kiski?
Yep. Can you show the IVUS on the screen?
And Anu, one quick thing with the stem cell transplant impending in this near future, you're probably going to try to make this as simple as possible, because the DAPT is a real issue. Because the stem cell be done, the patient's going to get pancytopenic. So you're going to try to make this as simple a stent approach as you can, right? Is that what?
That is the plan. Yes, that is the plan. But of course, I think we thought we will image and see if ramus. I mean, based on the angiogram, I think ostium looked okay to me. But we have done the imaging, which you can see.
So we use the Boston Scientific Avigo Plus.
Sorry to interrupt. Go ahead.
AI integrated high definition IVUS. This is from mid LAD to this is ostial LAD, left main, and go to the guide. So I focus on the calcified part. So this is a proximal LAD. You see the 9 to 10 o'clock, there's a protruding calcified nodule. The surface is smooth, so we can call it a non-eruptive calcified nodule. When we go back to the ostial LAD, it's very focal, but you see the 270 calcium arc. And I go back to the left main, just this before the circ. This is a distal left main. And the area-wise is 4.5 based on the IVUS, and with a 270 calcium. So this left main is definitely tight. And calcium score, we have a 270 calcium and a calcium nodule. So IVUS score is 2. So we think we need additional atherectomy devices.
So essentially what we are saying is, the arc of calcium, we are getting three quadrants, and then we have a calcium nodule, though we don't think the length is not more than 5 millimeters, but either way, IVUS criteria greater than 2, so make it severe. I did hear the discussion of your previous case, in this kind of situation, what should be the question would be the same. Should any kind of atherectomy device be used? I think we all feel atherectomy device should be used for proper lesion preparation and stent optimization. What should be the device that we should be using? We felt that since it is a short lesion, that IVL should be okay, just IVL. But if anyone feels different, then we are ready to do rotational atherectomy also. But if you go back to the IVUS analysis, you see that the lumen, the diameter there is already 1.6. So 1.7 burr barely may do anything. If you need something, we will need like a 2 burr from left main to LAD. Yeah. So other than that, can we just do IVL? So I want to know what you guys think.
Yeah, I'd be curious. For me, I totally agree with your assessment. Maybe orbital will get it, but I don't think you need to do it. Honestly, there's some people who would say do cutting balloon in this situation to see, whether that alone modifies it. But Azim, what are your thoughts? I think we need more study of this. Azim?
Yeah, absolutely. I mean, I think a short lesion, you're trying to keep it simple. If you look at some of the areas, the residual lumen is actually quite large. So if you were to go with rotational atherectomy, you need quite a large burr. I like the idea of using IVL here. I would either in my practice, it would be IVL versus high pressure Wolverine. Those would be the two options we'd probably try.
And Anu, you keep working. Valeria, what are your thoughts?
Yeah. So what we decided is we'll take the IVL. Since we image the ramus, I have left the wire in the ramus anyway, which we can leave if you're doing IVL. So we took a 3-5 just because if you go to the LAD, right, we are going to use the same IVL balloon both to the left main and LAD. So we took a 3-5, all the left main. I think we are getting like a 4-5 diameter. So we will go. Yeah. So you see that? Yes. So other thing is, remember RCA is total and VA is the left main IVL, so we got to be very fast. Yeah, go.
Dr. Kinney, osteo limas area is 5.0, so it's not obstructive based on the initial IVUS of the limas.
Go 6, I think.
I have to say that the use of cutting in this case, I mean actually the effectiveness of the Wolverine, how a cutting balloon on a calcific nodule is not really well demonstrated in literature. So I think the data we have with IVL are more robust. And we also take advantage of the fact that we can leave a second wire. It's a bifurcation, so that's also nice as compared to atherectomy device. So I think it's a nice choice.
Yep.
Can you show the hemos by the side?
Well, I think the nodule is pretty small and it's not that protrusive and it's localized about 90 degrees of the vessel. There's not much associated concentric calcium. The 270 calcium in the distal left main is over a very short length. So I think IVL is a reasonable choice, but I think you also might just dilate all this effectively with a big non-compliant balloon because the calcified segments are focal. So that would also be an option. We're obviously always worried about that in the left main. But you could do an NC balloon via IVUS and then use IVL as your second choice. Would be my strategy.
Anu, it looks like the hemodynamics are okay. Sorry to talk over you, Mark. Anu, it looks like the hemodynamics are okay. Or am I seeing that right? I mean, I'll just
it's okay. But you see that I have the guide outside. Okay.
Yeah.
Good. Hemodynamics are great.
Guide is disengaged. And remember, the balloon's 3.5, so it's not going to obstruct the left main because it's 3.5. So you're still probably having some flow down the circ, maybe some flow down the ramus. If you wanted to test to figure that out, you could just do a little injection and see and make sure that's the case. And especially in an occluded right, that's important. I remember when IVL came out first, there were a lot of people saying, oh, if I use IVL on the left main, I'm going to need to put an impella in and things like that. And I would say in most cases, you don't need to do that. And there's not really that many issues, even if you're inflating in the left main itself.
Just deflate it.
But yeah, sorry to interrupt.
Okay, ready?
It just deflate at that point.
So Ajay, I mean, you guys are doing a study, a randomized study comparing IVL and cutting balloon, right? What kind of lesions and how far enrolled is that study?
It's a little P.
So I just got an update today, and we were actually, there's two cohorts of patients. One is non-atherectomy patients, one is atherectomy. The non-atherectomy cohort, which is cutting balloon versus IVL, is fully enrolled. Honestly, this case would have qualified. So I think it would have been a great case to study that in. The atherectomy cohort is after you do rota, you then randomize to IVL versus cutting balloon. And the imaging endpoint is the one that's being assessed. And we hope to be able to present that at TCT. So we're almost done.
Show the IVUS.
Which is pretty cool because then we'll have some randomized data.
Okay,
I'm looking forward to see that, especially since I seem to be the only one out of the
IVL
who likes cutting balloons.
Yeah, a lot of dissection.
Oh no, I use cutting balloons a lot actually in my practice. I'm a real
I will stop it.
back to them. See, because of the trial, actually, I've really converted back to using them much more than I was before the trial, which
Yeah.
has been interesting.
Yeah, huge dissection, opposite to the calcium perk.
Yeah. The, angiographically also we could see maybe a little bit, I would say, contained microperforation in the LAD. So let me go back. If you see that, you see that?
You can show the angio.
Can you appreciate that? In the
Yeah.
proximal ostial LAD, yeah. And you see that in IVUS you're saying?
Yeah.
So it's in the opposite part where the
Yeah.
normal looking vessel, yeah. I mean, we
Mhm.
went 3.5 and barely like 4 atmospheres. Okay.
Very focal. It's not flow
I
forget
mean,
to
you
the
can
distal.
get these things. I think, yeah,
Okay.
it's
So
rare.
I
but
think
there are
Ramus looks
cases where
good,
even IVL.
right?
Yeah.
Yeah, Ramus looks good. If
Yeah.
everybody agrees, do
Yeah.
we just go ahead
Yeah.
and stent it now? It's
I
fully
think so.
expanded based on the, right? We don't need to dilate again.
I think so. The area-wise is much bigger. Of
Yeah.
course, this IVUS resolution, we cannot see the fracture in the nodule, but lumen-wise, it's much bigger than the previous.
Okay.
And a lot of dissection. It's a
I
good
think we
plaque
will
modification.
just stent. So we'll go with the 3.5/28 and
Yeah.
then we'll post dilate into the left main. Anything else you think, any different way?
No, I think. No, I think it's great. The one thing I would just comment on is that the use of the score to determine when to use advanced modification. I mean, for us, it's really the 4s that are the ones where we're using advanced modification. At 2 and even 3, we will tend to try NC balloons or other things like that, especially that length issue. Because for me, the length is really the most important thing. Honestly, if you have a short focal 360, that will often crack. So I don't think there's anything wrong with doing it this way. It's a very efficient way to do the case. But this is, I think, why we need more detailed data and analysis, because I think many times these types of cases, it would have worked with either NC or scoring or cutting, but this is reasonable too. So I'm curious to see, it's going to look good after stenting, and then we can maybe talk about the whole DAP situation too afterwards. So you're going to size to the distal vessel for the audience.
I'm going to, yeah,
size to the distal vessel,
yes,
and
someday.
make sure you take a stent platform that can expand enough for the left main.
Okay,
So
no
that,
die.
Ajay, that appearance
Wait.
that we got with the extensive dissection, I think you more often see that when you've got a combined fibrocalcific lesion. Because as you
come
mentioned
back a bit.
earlier,
I'll pull back.
IVL is actually hazardous in fibrosis. In isolated fibrosis, it can cause extensive dissection.
Sandai,
I've seen that
yeah.
in a case before
Yeah,
where
Okay, good.
looks
somebody
okay.
used it
Okay, go.
without imaging,
We
thinking
have a
it was
4.5
calcium and it was
strand.
all
Yeah, we
fibrosis
have
and the
4,
whole
5.
vessel tore. So I think
This is
here
the 12.
probably a combination of calcium and
12
fibrotic
only.
disease, and that's why you saw that, I think.
You went up, right? Okay.
Only 12.
That makes good sense.
4, 5 balloon.
Now this calcific nodule again, I mean, we actually published, we presented in ESC, and we have published about
8.
how to take care of nodules, because one sticking factor in the calcium is always when we are seeing a nodule. So this nodule was less than 90° and superficial calcium, so we knew would respond well. But otherwise, if you have severe calcium, 360° of calcium plate around it, and we have been through that cases that you will never see, not able to deliver anything, and then we are trying to expand later, that becomes an issue. But I also heard Ajay, you mentioning that
you
if
don't wanna
we
do that.
use, if we are, you do some kind of atherectomy, you did cutting balloon, high pressure balloon, place a stent, and you still think that we are not able to get a good MSA, we do have, like you mentioned earlier, that we do have the IVL, which we have done in freshly placed stent. So I'm going to remove this side branch wire now before we do optimization. This is a 458.
Yeah. That means 4, 5 vessel.
Yeah, okay, good. Okay, go here. Can you see it? That we are in the right spot.
So this pot is super important because it makes you really oppose nicely
10.
in the left main. It'll actually open up,
12.
hopefully, the struts towards those side branches
Yeah,
too.
don't.
So don't omit this step. It's a really important step.
Are you, Andrew, can you show the video
Now,
for the provisional stenting? Go. So we do have our
6, 8.
app that we are going to show you by the side.
Just for its
So that's ostial LAD. We dilated again. We're going up again here. Go.
This.
Yeah, that's it. Not too high, right?
No, no.
Just going to
And we
expand on
get
what
IVUS
Dr. Penny
ready.
was saying about the atherectomy. You know, there's some messaging going around that atherectomy doesn't reduce volume of nodules in coronary arteries, and it isn't true. You know, there's now some data that shows that if you've got a truly protrusive nodule, you can reduce the protrusion by almost 30% with atherectomy. So the kind of messaging going around that you don't need to reduce the protrusive volume of a nodule, a significant nodule in a lumina, I think should be countered with that data.
Yeah, no, good point. So this is the Bifurcate app, right?
Yes, yes. So this is animation 3D. We just did provisional. You can show if we have to do, Andrew, um, the next bailout, if you need bailout.
So Anu, are you gonna rewire the two side branches and dilate those struts, or just leave it like this where it looks pretty good?
I think I'm not a fan of rewiring and doing, dilation. So we are the ones that are actually published based on the Excel data, that once you did the left main stent, actually if you did
Now we do IVUS.
single stent strategy and did kissing balloon, the outcomes especially slightly, not statistically significant,
show
but
the IVUS on the
slightly
screen?
increased stent thrombosis. But they were old stents. And during the Excel time, the technique was not
start with
well defined.
it already. Yeah, good position.
Some of it though may also just be confounded by the fact that those patients in whom you have to go back and kiss are probably sicker in some way or another. I mean, Excel was EES, and the use of IVUS was in at least 3/4 of the patients. So it's pretty reasonable. But I think your point's well taken. I personally would not go back and wire the circa the ramus and dilate them. I think if
let's ask the panel.
it does and all of that, I think you're okay. Yeah, anybody who
also
wants to
think
raise
in
your hand
this
if you want to go
patient-
back and.
Or even ask, you can ask a question, right, Paul?
There's a chance they're going to become thrombocytopenic in the future with the bone marrow transplant and so on. Having one large stent that's not deformed makes me feel the most comfortable. I like this strategy.
Valeria, would you rewire and dilate? The Europeans are very, very meticulous and prescriptive about this. So tell us, no?
That's true. That's true. But despite that, even the EBC recommendations, I mean, there's no evidence that routine systematic kissing balloon after crossover stenting actually leads to a better result. So I think in this case, angiographically, both side branches look very good. So there's no reason to proceed with kissing balloon.
Agreed.
You want to go over the
We got to
IVUS?
go back to Nicholas, but Anu, tell us, what are you going to do with the DAPT? It looks good to me. Yeah, you can go over it real quick.
Yeah, go over anything we need to be worried about, Kiski.
No, it's area-wise very great. Distal left main area-wise 12, and a cursor nodule part is eccentric shape at area-wise 7.0, and the distal edge cover the dissection, normal apposition. Proximal edge is at the ostial left main. So IVUS it's perfect.
Perfect. Okay, so beautiful. He says he's happy.
Yeah, and
we have to make sure our IVUS colleagues are happy.
Really helpful.
Yeah. So going back to the DAPT will be PRU. Yeah. So what happened is, remember, he saw the surgeon, and then when we decided he's coming back for PCI, the primary cardiologist did talk to me, and we put him on Plavix. Do we have his platelets? Oh, platelets are 471. We don't have to worry. And PRU is 64 in a week of Plavix therapy. So if everything good, since we did IVUS, I think we'll be comfortable, though it is left main, right? For stable now it is 6 months, but since we have IVUS guided PCI, we should be okay to stop in 3 months.
Yep.
What do people feel?
When will you let them go for the transplant, the stem cell transplant? No, I agree with you completely. But the transplant, will you let them do it at 2 months, 3 months? When is that going to happen?
So that's another thing. So if we first thing we need to ask with do they need interruption or complete stoppage? I think we'll be comfortable at 3 months. End of 3 months, I will let the patient have clear for transplant.
This is a great demonstration. We're going to leave you and jump back to Nicholas so he can show the final result. But it was a lot to cover. You did it as a pro, as you always are, with your whole team. And thank you so much for really enlightening us.
I just need to show. Can you show the first final slide, because a lot of people online. So we have that our app. So cardiologyapps.com slide. So people, for the younger generation fellows who are online, they should be able to put that slide on quick.
Can you switch to their slide?
Yes. Yeah. So if they go to cardiologyapps.com, so we have 14 educational apps. They are free to be downloaded, both on Apple and Google Play. Everything is there. So next one we are doing will be the hemodynamics one. Thank you for inviting us.
It seems like an ad, but it's free. It's genuinely free, so it's good. So it's all good. Thanks, honey.
Okay, bye-bye.